Hello, this is Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show, a podcast series that seeks to demystify mental health treatment. Today, I'm honored to welcome Dr. Anna Lembke, who is an associate professor in the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine. She is the medical director of Stanford Addiction Medicine, program director for the Stanford Addiction Medicine Fellowship, and chief of the Stanford Addiction Medicine Dual Diagnosis Clinic. Dr. Lembke was one of the first in the medical community to sound the alarm regarding opioid overprescribing and the opioid epidemic. In 2016, she published her best-selling book on the prescription drug epidemic, Dealer M.D, How Doctors Were Duped, Patients Got Hooked, and Why It's So Hard to Stop. Her book was highlighted in the New York Times as one of the top 5 books to read to understand the opioid epidemic. Dr. Lembke, welcome to The Therapy Show.
Thank you for having me. I'm so excited to be here.
Can you start by telling us a little bit about your personal background and professional development that led to your research in the field of addiction?
Sure. So I went to Stanford Medical School, and then I graduated and went into psychiatry here at Stanford in our residency program. And if there was one thing I knew when I was going through my psychiatry residency, it was that I did not want to treat people with addiction. And the reasons for that were many. One was that I hadn't really learned much in medical school about addiction, so I didn't know how to do it. The second was that I really hadn't learned much in my psychiatry training about addiction, sadly. And also I had quite a bit of negative countertransference because my father, who was a surgeon, was a high-functioning alcoholic. And I just really didn't feel like I wanted to deal with, quote unquote, those people, even though I really loved my dad and we had a good relationship despite his alcoholism. But what happened was, as I was a budding young psychiatrist here in the department in our mood disorders clinic, I realized that my patients were not getting better. And that part of why they weren't getting better was because I was not addressing their co-occurring substance use problems. And there was one particular incident that led me to believe that not only was I not addressing their substance use problems, but I really wasn't a very good psychiatrist in not doing so. So there was one pivotal case with a patient who had been using heroin and almost died as a result. And I had never even asked her about drug or alcohol use. She and I had talked about every conversation she'd ever had with her mother growing up. I did my due diligence to Freud, but I never did ask her about substances until she almost died. And so that was really a professional awakening for me, realizing that I was remiss in ignoring that whole area. And so I set on a journey. This was about the year 2000, beginning of my career. I decided I had to re-educate myself, learn about addiction, because otherwise I was going to be harming patients. So that's what I did. I talked to colleagues who knew about addiction medicine. I went to conferences like the California Society of Addiction Medicine Conference. I talked to patients. Probably my best teachers were my patients. These were often individuals who were in long-term recovery, seeing me for other reasons. So I learned all about recovery from them. And I eventually grew to really, really like the population and to find treating addiction incredibly rewarding. Because when my patients were getting better in terms of their addiction, it just had this incredible ripple effect. Not only were their lives better, but the lives of their loved ones and really everybody they came into contact with benefited. And so I sort of became the go-to person in my department, also in part because nobody else wanted to treat this population. And eventually, I guess I became quite zealous about it and really very determined that we had to radically change the way that we train physicians and that we had to really teach docs how to screen and at least do some preliminary intervention for substance use problems, or we were not going to be able to help them with all of their other problems, including their medical problems. Then around 2005, 2006 was sort of the growing prescription drug problem, prescription opioids, prescription benzodiazepines. I was seeing more and more of my patients misusing and getting addicted to pills that their doctors were prescribing, including, by the way, pills that I was prescribing, stimulants and benzodiazepines. And so then I also became very interested in that problem. And essentially since then, one of the major areas of focus for my scholarly work has been specifically the overprescribing and overconsumption of addictive prescription drugs. Although I treat all kinds of addictions, I would say in the last 5 years, what's really coming to the fore in my clinic and also in my research and scholarly work is also process addictions, or sometimes referred to as behavioral addictions. These are things like being addicted to gambling, shopping, pornography, video games. So that's my professional development.
So how would you briefly explain addiction to a non-professional?
Addiction is the compulsive, continued use of a substance or behavior despite harm to self and or others. Of course, there is the DSM-5 criteria, 11 criteria. Depending on how many criteria you have, you meet either mild, moderate, or severe definitional criteria for a use disorder. I find that the DSM-5 criteria can be near impossible to remember. So a sort of shorthand version for thinking about those criteria and how we diagnose addiction is the 3 C's. The first C stands for out of control use. The second C stands for continued use despite consequences. And the third C stands for compulsive use, which means a lot of mental real estate taken up with thinking about getting the drug, using the drug, hiding the drug from other people, and also a certain level of automaticity around the use. One of the things, though, that it's worth pointing out is that in the DSM-5 criteria, as well as in the 3 Cs, there is no mention of quantity or frequency. And that's not because quantity and frequency aren't important. In fact, we do know that daily use is highly correlated with addiction. And we know that people who use in higher quantities, whether it's binge use or daily use, are more likely to have a substance use disorder. The reason that it's not among the DSM-5 criteria is not because it's not important. It's because they wanted a unifying definition for all different substances. And it was impossible to do that, to quantify what the limits of moderate or normative use are for most substances. We don't have good data for that. We actually do have good data for alcohol on that, but not for other substances. Like we don't have science around like, well, what's a moderate recreational safe amount of heroin use, for example? We don't have that. But we also don't even have it for cannabis use. What is sort of appropriately social, recreational, non-harmful cannabis use? We don't have good data for that.
And I think it allows for something like gambling addiction to be brought in the overall category.
There were several innovations in the DSM-5, and one of them was that gambling addiction was added as a DSM-5 diagnosable addiction. And video game addiction and shopping addiction, pornography addiction, not yet, but those will likely be added in the future is my guess.
Can you talk about what's happening in the brain and the body when someone becomes addicted to either substances or something like gambling or internet addiction?
There's a lot of interest. Let me just first say there's a lot of fascinating neuroscience in the last 50 to 75 years in the field of addiction. And unlike other psychiatric illnesses, we have good animal models for addiction because you're dealing most of the time with an actual substance, a rat pressing a lever for cocaine, etc. So there's a lot of great science. It's a very, very exciting time to think about what's happening in the brain. We know a lot more than we did 50 years ago. And I think to sort of boil it down to its essence, the difference between a substance or behavior that is addictive versus one that is not is that an addictive substance or behavior releases a lot of dopamine in the brain's reward pathway. And that reward pathway is made up of a neural network between the ventral tegmental area, the nucleus accumbens, and the forebrain. So what happens when I use something that is highly reinforcing / addictive, it releases a whole lot more dopamine in that reward pathway than, say, for example, broccoli does. I have never heard of anybody getting addicted to broccoli, so I'm using that example. The key thing there is that the brain, we are wired for millennia to approach things that are positively reinforcing, i.e. pleasurable, and to retreat from things that are painful. And we have an extraordinary capacity to encode memory for things that are pleasurable and approach-worthy and things that are painful and avoidant-worthy. But with repetition, those things that are pleasurable become less so over time. And often it's true that things that are painful become less so over time with repetition. And this occurs through a process called neuroadaptation. What essentially happens with addictive substances that are used repeatedly is that the brain starts to downregulate its own dopamine receptors, because basically it's saying, well, I'm getting all this dopamine from the outside. I don't need as many of those receptors in my reward pathway, and I don't need to make my own dopamine. As a result, with time, the brain essentially goes into a dopamine deficit state where nothing else is enjoyable except using my drug of choice. And when I'm not using my drug of choice, I'm essentially in a chemical depression because I don't have a normal amount of dopamine. And this is what George Koob has called, he's a neuroscientist, has called dysphoria-driven relapse. That folks who become addicted get to a point where they need to use their substance, not to get high, but just to feel normal. And that's essentially this process that occurs as people progress from intermittent, modest recreational use to heavy dependent use that leads to almost insurmountable physiologic drive to seek out and obtain the substance. Again, not to get high, but just to preserve homeostasis.
So what about the body? What happens to somebody's actual physiology?
Well, the body and the brain are intimately connected, and drugs are the great mimic, especially when it comes to psychiatric symptoms. The way that the body responds to various drugs really depends on the drug. If we're looking at the class of drugs that we call stimulants, that would include nicotine, that would include cocaine, that would include methamphetamine, that would include coffee, caffeine. Those essentially rev up the body by, for example, increasing the release of norepinephrine alongside the release of dopamine. So we get into a hyperphysiologic or a state of hyperarousal. But really, remember, every time what goes up must come down. So the state of physiologic hyperarousal triggered by stimulants will be followed by a come down or a withdrawal that is the opposite on the body as whatever the drug originally incited. So the come down typically from a stimulant will be sedation, grogginess, lethargy, cognitive slowing. The same thing is true for sedatives like alcohol or benzodiazepines. They essentially slow the body down, slow down the heart rate, slow down mentation. People feel relaxed. And then the opposite during the come down is the state of hyperarousal, agitation, restlessness. I will add, though, that everybody's unique and there are enormous individual differences. Some people who use a stimulant will feel calmer after using that stimulant. Likewise, think of opioids. What comes to mind is opium dens and people prostrate, unconscious, asleep from opioids. But many people who become addicted to opioids will report that opioids are in fact activating for them and energizing and give them energy. Whatever your reaction is to a given drug, the come down or withdrawal from it will be the opposite. It's really important to know that, too, that addictive substances can have serious end organ damage, depending on the substance and depending upon the route of administration. So, for example, smoking anything is very bad for your lungs. Alcohol is very bad for your liver and for your pancreas. It's not the only substance, but it's probably the most well-known substance that can contribute to things like alcoholic liver cirrhosis. Stimulants are very bad for the heart. They can lead to a cardiac arrest. They're also very bad for vasculature in general, leading to stroke. And I think it's also important to recognize that every addictive substance does end organ damage to the brain, in that you build up this tolerance after a while, needing more and more to get the same effect. Through this process of adaptation and sensitization, you're then very focused on that substance. Nothing else is enjoyable. And then, as I said before, you need to use just to feel normal.
Why is early assessment and intervention so critical when treating people with addictions?
Every illness, whether it's a mental illness like addiction or a physical illness, the earlier we get in there and intervene, the better off we'll be. When it comes to adolescence or the life development, it's very important to get in there during adolescence because this is a critical developmental time in the brain. And this is the time when we're pruning neurons so that we're left with just the neurons that we need most and use most. And we myelinate that scaffolding to be especially efficient for the tasks in life that we need to do. And that occurs between about the age of 13 and 25. But you can imagine that during that key process of pruning, neuronal pruning, and myelination, if you're using addictive substances or addictive behaviors as a coping strategy, then that's going to work into general scaffolding or lattice work of your brain, making it potentially that much harder to develop new lattice work by the time you're 25, when the neurons, have less capacity to generate new neurons and when we're past that pruning period. Having said that, young people do have much more plastic brains than older folks, which means that there's a lot of hope, even with young people who do develop serious addictions. If they do get into recovery, they can have very good outcomes, even if they've had many years during adolescence where they've used substances heavily. I find one of the trickiest populations to treat is actually older people over the age of 65, because they've lost so much of that neuronal plasticity.
Why is it important that therapists who are treating individuals with addictions have some formal training in this disorder before working in the field?
Well, I think that the default in mental health is to not ask patients about substance use unless you're working in a dedicated addiction treatment setting. And the resistance to asking about substance use problems is very natural. It's because patients don't like talking about those issues. And so it potentially threatens the therapeutic alliance if you don't know how to have those conversations empathically. So training is really, really important in order to know how to have those conversations and bring up the difficult topic, the highly stigmatized topic of substance use and addiction. But I can tell you, once you get that training, it's a very rewarding conversation to have. Patients are willing to engage in that conversation, and it can have a huge impact on whether or not the patient gets better. But I do think specialized training is required to know how to bring up the touchy subject of substance use and addiction, to know how to empathically engage patients around that topic. That's particularly true in my experience if they're misusing prescription drugs, which I may actually be providing to them, which complicates the dynamic further. All addictions, there's enormous shame. And I'm finding more and more my patients with sex addiction are so full of shame that it's very, very difficult for them to talk about these topics. So I do think that specialized training is important. I will say, however, that the push in addiction medicine is for lots of people in all different mental health settings, and even not mental health settings, primary care settings, other medical settings, to be well versed in at least how to ask some of the preliminary questions. Because if we wait for addicted patients to sort of show up in our addiction treatment specialized clinic, we're going to miss about 90% of our addicted patients because they don't go to specialized clinics, right? They show up in the primary care doctor's office. They show up in the ED. They show up on the trauma unit. So we all have to learn some basic information about how to screen for this problem if we're really going to be able to serve patients struggling with these issues.
And one of the things I found working in a hospital setting is if you don't know how to ask the right questions, the person might go in for either heart surgery or routine leg surgery or setting a bone, and they come out on the other side of the operation in withdrawal, even if they're not an addict. Does that make sense?
That's a great point. Basically, in not asking our patients about substance use problems, we are harming them because in ignoring that really important piece, we're putting them potentially at risk for accidental overdose, for life-threatening withdrawal, for egregious harm to their careers, their relationships. Typically, our treatments for other mental health care conditions, whether the treatment of psychotherapy or medication, don't work when people are actively in their addiction. We really have to concurrently treat the substance use problem and the co-occurring mental health disorder in order to get traction on either of those disorders. Neglecting this problem, ignoring it, which I did for years, it's not a zero-sum game. We're actually harming people by not paying attention to their substance use problems. The other thing, too, is that we, as very well-intended mental health care providers, can enable our patients' addiction if we spend all of our time with them talking about other problems and never raise this problem. So as I alluded to in one of my patient early in my career, I talked to her about every conversation she'd ever had with her mother, but I never once asked her about her substance use. And in a way, she was paying for her visits to see me. Her family was paying for that. And they assumed that she was coming to see me and getting help with her heroin use disorder, when in fact, that was not happening. But she could kind of hide behind that and not address her addiction and use me in a way as a shield. I think it's really important that we not enable that process of kind of wanting to deny or hide from the substance use problem, which I think can happen a lot. Patients saying, well, I'm going to this doctor and I'm getting psychotherapy or I'm getting meds, so I'm dealing with my stuff. But if the psychotherapist or the psychiatrist is not addiction informed and not addressing that problem, then really we're not, I don't think, helping the patient as much as we could or should.
It is in that assessment. That assessment has to be skilled.
You have to know how to ask the questions. You have to do it empathically. In some ways, you have to do it matter-of-factly, too. Like, hey, these are the questions I ask everybody. Do you drink alcohol? Do you use cannabis or other drugs? How often? How much? What's that been like for you? Why do you use those substances? What's the good, the bad, and the ugly about that? How do you think it affects your depression, your anxiety, or what have you?
And I think that in our field, oftentimes we're trained not to put words in our patients' mouths, but oftentimes we have to give them some language to work with.
We do put language in their mouths. They have PTSD in their mouths. They have major depression. They have language. We've given them that language, and they come in talking with that language. But absent from the language that we've given the last 3 generations of mental health care consumers is any language about how to talk about substance use or what it does to the brain or how it might be adversely impacting their lives.
Do people suffering with addictions have a higher rate of suicide?
So it's definitely a risk factor for suicide. There are some really famous old experiments where hospitalized patients with alcohol use disorder were given access to a free open bar and got intoxicated. And then they were interviewed about suicidality. And I don't remember the percentages, but a good portion of them became actively suicidal while they were intoxicated when they hadn't been prior to imbibing. And the really interesting part about this experiment is when those individuals were interviewed after alcohol was taken away and they got sober again, the vast majority of those individuals didn't remember anything about endorsing suicidality while they were intoxicated. So something very unusual happens, well known, that people can become actively suicidal when they're intoxicated, even when they are not suicidal at all, when they're not intoxicated, and they have no memory for that suicidality. We do know that the majority of suicide attempts and suicides that do occur with addictive substances in the mix. Now, how big a role that played, it's hard to know. Some people who want to end their lives might not habitually be using substances, but they might use the substances to overcome the inhibition to take their own life. But in many instances, these are people who probably wouldn't have even attempted to take their lives had they not gotten intoxicated.
And I think it's interesting that oftentimes people think I'm going to take a medication or a drug that's going to calm me down, but it might even have the opposite effect, like you mentioned earlier.
And it can lead to I think a lot of people sort of experience, they get more depressed on all kinds of substances. They hear voices, they become disinhibited, they experience derealization or depersonalization, all of the things that can contribute to thoughts of suicide.
Can you talk a little bit about the current treatments that we have for addictions?
Addiction is a complex biopsychosocial disease. Its etiology can be traced to biological factors, psychological factors, and social or environmental factors. So, using that rubric, it means that the treatment interventions also need to address biological, psychological, and social aspects of the illness. When we look at biological factors, we can't change people's DNA, but we have a lot of exciting ways and new ones all the time to try to impact the brain itself. And we can do that with medications. So there are 7 FDA-approved medications to treat addiction. There are 3 medications to treat opioid use disorder, 2 FDA-approved medications to treat alcohol use disorder, and then there are 2 medications to treat nicotine use disorder. In addition to the FDA-approved medications to treat those disorders, there are many off-label medications, many medications that we use off-label to treat a variety of substance use problems, some of which have been shown to have really excellent efficacy. Medications are potentially helpful nudge for people with substance use disorders. We don't have a medication for every substance, but we have some very effective ones for the substances that we do have. And I would add that these medications are way underutilized. They're among the least prescribed psychotropics that we have, and yet their efficacy is on par with the efficacy of antidepressants. We get about a 50% response rate, all comers. Other exciting biological interventions include things like transcranial magnetic stimulation, as well as even some very preliminary research for deep brain stimulators. These are devices that give an electrical impulse that are inserted directly with wires inserted directly into the brain. Right now, there's no FDA-approved indication for TMS or DBS to treat addiction, but it's very likely that in the next 6 to 12 months, the FDA will give approval for RTMS or transcranial magnetic stimulation to treat nicotine use disorder, because the research now is at a point where we have enough data there showing enough efficacy that we can probably get approval for that. So that's the biological piece. In terms of psychotherapy, there are lots of validated, evidence-based psychotherapies to treat addiction. DBT, dialectical behavioral therapy, CBT, cognitive behavioral therapy. We've got specific therapies that work on relapse prevention. We've got therapies, family-based therapies that are very effective. All of these have been shown to help in the treatment of substance use disorders. There's also something called contingency management therapy, which is very underutilized, but has a robust evidence base. And basically, contingency management therapy is a way to use rewards and punishments to shape behavior. Typically, the way that it's done is that for negative urine screens, patients are given, for example, a $10 Starbucks or Amazon voucher. And this has been shown to be an effective way to increase the number of abstinent days and the number of negative urine screens. What's not clear is how contingency management works in the long term. But when we fold contingency management strategies into our criminal justice system, it's been found to be helpful in that arena. For example, there was an intervention study in South Dakota, which found that when people had driving under the influence convictions against them, and they were mandated to wear an alcohol or a breathalyzer, some kind of monitoring device, an alcohol monitoring device, that if people tested positive while they were on parole, tested positive for having used alcohol, if they knew that immediately they would be spending that night in jail as a swift and commensurate, quote unquote, punishment for relapsing, that greatly reduced the chances of relapse. In contrast to a relapse being associated with a vague possible 2-year jail term. So what contingency management has shown is that you have to have a swift and certain punishment, which is commensurate with the transgression or crime, not a vague, uncertain long-term punishment, because that doesn't work as well. Any parent out there will tell you that when you're potty training your kid or whatever, if you promise them one M&M for good behavior and you give it to them as soon as they do that behavior, you get much better traction than if you say, I'll give you an M&M a year from now if you do X, Y, or Z. That's the idea with contingency management. In terms of social interventions, so now we get into policy. There are lots of policies that have been used to try to help the problem of addiction on a population scale. Some of them have been colossal failures. For example, the war on drugs, which is also highlights the structural and endemic racism in this country, was a colossal failure and ended up just imprisoning lots of brown and black people without getting anybody into recovery from addiction. But there are other public policy interventions that can structurally change an environment that do have a positive impact. The opioid epidemic, some policy interventions for that are good examples. Mandates to reduce opioid prescribing on the part of physicians, better access to addiction treatment for patients. Those are policy interventions and environmental changes that have made a difference. Also in the environmental group is just peer recovery, which has been one of the most remarkable social movements of the last 100 years is Alcoholics Anonymous. And a Cochrane report just came out affirming what we've known for a long time, but with new and improved data, that for those who actively participate in 12-step recovery, the outcomes are very good, possibly better than professionally led individual psychotherapy, especially the further out you go. And then, of course, when we think about deaths of despair concept that, as Freud said, in order to have a rewarding life, we all need work, love, and play. And there are lots of people in this country who have none of those things, and they're at greatly increased risk for addiction. So improving the quality of people's lives down to the kind of work they have, the families that they live in, their access to healthy food and nature and strong social networks, these all play a big role in addiction risk and prevention.
Each substance that a person is using causes a different effect on the brain and the body and even their lives. What you're saying is, I think it's so important to have that targeted treatment. And so if somebody has an alcohol use disorder, there's a type of medication that may help and may not help with all the other addictions. But if somebody has an opioid addiction, they may want to take a different medication. And again, that's between them and their psychiatrist, but sometimes the psychiatrist doesn't know or doesn't prescribe them. I think it's just what you're describing is the complexity of this problem.
You're absolutely right. Psychiatrists are woefully undereducated about addiction, about the medications that can be used to treat addiction. And it's really a great injustice to our patients because I have some patients who, for example, they've struggled decades with a certain addiction. I prescribe them a medication used to treat, for example, alcohol use disorder, and it really is like a miracle drug for them. They had that access to that drug years earlier, saved them many years of suffering. So it's really important that we recognize that everybody's going to respond differently to a given addiction treatment. And what's right for one person is not going to be right for another person. And that's exactly why each person should have access to all the different types of treatment so they can find the combination that works for them.
What do you see as the biggest obstacles that people experience of achieving a full recovery?
I actually think the biggest obstacle is this crazy world that we live in with near ubiquitous access to high dopamine substances at every turn. And even when people have loving relationships, meaningful work, a purpose, good physical and mental health outside of their addiction, the world is just full of temptations, a consumptive world. So there's enormous risk for all of us to get addicted to something. So I think that's one of the big challenges. And then in terms of just the more practical challenges, addiction treatment for a long time wasn't even covered by standard medical insurance. It's gotten a lot better now with the 2007 Mental Health and Addictions Equity Act, but it still can be very difficult to find an addiction treatment specialist, somebody who's informed and knows how to provide this treatment. And even when you find that, it can be very difficult to find a way to pay for it.
Isn't relapse part of the addiction process?
We conceptualize addiction as a chronic, relapsing, and remitting disease, just like various forms of heart disease, just like diabetes, just like major depressive disorder. People can go into remission for years at a time, but it's very common for people to relapse, which is why the treatment has to remain accessible. And in many instances, why there have to be continued interventions lifelong, continued participation in biopsychosocial intervention for the disorder. Importantly, what I teach my medical students and residents is that when a patient comes in saying that they've relapsed, that the appropriate response to that is, "I am so sorry for you. My heart goes out to you." Just like you would say to a cancer patient who discovered that they had a recurrent growth of their cancer. This is a disease. It's not necessarily within a person's willful control. And when they relapse, it's evidence of the disease process manifesting again, not evidence of moral turpitude or lack of willpower or some other moral failing.
What are you most excited about in mental health treatment today?
I think I'm most excited about this younger generation of medical students and residents I see coming through who seem much more eager than prior generations, including my own, to learn about how to treat substance use disorders and other addictions, who have this real social justice mindset and want structural racism and structural sexism and poverty and unemployment to really more fully inform the work that we do in medicine, which I think is absolutely spot on, because medicine has in fact become the social safety net in this country. So I'm excited about these young people and their brains and their energy and how they might change medicine going forward.
If you had a magic wand and could improve one thing about mental health treatment today, what would it be?
I would love to see mental health treatment and addiction treatment and medical treatment all consolidated under one roof. The silos of care make it very difficult for people to get the treatment that they need. The way that there's this constant churn and disruption in care providers and insurance coverage makes it very, very difficult for people to get the kind of care that they need. I'd love a one-stop shopping. You walk in, you say, "I have an opioid addiction and I have an abscess and I'm depressed." And it would be really great if that person could get all those things cared for in one place.
And I think that if we pay now, we don't have to pay later in terms of the social consequences that addictions have on our society and the structural issues. If we invest in our treatment, and especially with addictions, I think it'll help the whole society. I think everybody has an interest in this.
Absolutely. And the way to do that is to build an actual infrastructure inside of medicine to treat addiction. What we have now is no infrastructure in medicine to treat addiction. So we have these basically resources that have sprung up outside of medicine to fill the vacuum. Some of them are good, some of them are not good at all. Some of them cost a small fortune. Others are free if you check the right boxes. But it really shouldn't be like that. People should be able to go to their primary doctor or go to the emergency room, say, "I have addiction. Will you help me?" And the answer really should be a resounding yes. We can. We know how to do that. And yes, we will. And you will be covered for that by your insurance company or whatever your healthcare coverage is. We really have to build it. It's not going to happen naturally or by accident. We have to, with intention, build this infrastructure so that people can get the treatment. What I think is probably the number one public health problem outside of whatever killer virus is hanging out there that's going to affect our public health in the centuries to come.
Dr. Lembke, on behalf of myself, my listeners, and all of the people that you've helped through your work, I want to thank you for your contributions to mental health treatment and for taking the time out of your busy schedule to help me and my audience better understand the field of addictions.
Well, you're very welcome. Thank you for having me, and it's been a real pleasure to talk to you and your audience. I hope this is helpful.
So be sure to check out my website, therapyshow.com, which has many resources about mental health. There you will also find how to submit questions, stories, or insights that you have about the mental health system, or suggestions about who else I can interview and how I can improve the show. I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so that you, someone you love, and people around the world can gain more benefit from therapy. There's no need to suffer in silence. Get the help that you need to create the life that you want.